Welcome back from the break. I hope you took the opportunity to perhaps get away from the screen for a little bit and grab something to eat and move your body. Really excited for this next session as we get started with our afternoon programming. So young adults who are diagnosed with cancer face complex psychological and physiological challenges, particularly in areas related to fertility, intimacy, and sexual health, as we have heard throughout the morning. Chemotherapy, radiation, surgery, and some targeted therapies can impair reproductive function and hormone regulation. It can often cause infertility, sexual dysfunction, and disrupted identity during a critical stage of life. Despite guidelines recommending early discussion of fertility risks and preservation options, these conversations are often overlooked in initial treatment planning. Survivors may also face cost barriers to fertility services, compounding the emotional burden further. Many experience distress related to body image, intimacy, and future family planning, affecting overall quality of life and mental health. We are very pleased to host this important panel discussion, which will explore intimacy, reproduction, and fertility in early age onset cancer patients. This discussion will be moderated by our very own Christopher Mammoliti, CRAN's National Patient Programs Manager, our young adult colorectal cancer coach, and a thyroid and colon cancer survivor. Welcome as well to Julia Germania, a stage 4 breast cancer patient and advocate, Dr. Lauren Walker, registered psychologist who specializes in oncology and sexuality, Dr. Caitlin Dung, reproductive endocrinologist and fertility specialist, Dr. Trevor Cohen, gynecologic oncologist, and Liz Elwood, who is a cervical cancer survivor and an advocacy and patient education expert. So welcome to our wonderful panel this afternoon, and I'll hand it over to you, Chris.
Thank you so much, Cassandra. And hello, everyone. Thank you so much for being here and choosing to be here with us today. This is both to our panelists and our viewers. It's such an important conversation in the early age onset community. As Cassandra shared, I have in her lovely introduction, I have the benefit of moderating the session today. My name is Christopher Mammoliti. I am the National Patient Programs Manager here at CRAN, and I have the tremendous honor of supporting our cancer patients, our caregivers, through our programs, our resources, and our unique one-on-one connectivity calls. I have the pleasure, as I mentioned, of moderating this important and often heavily stigmatized and overlooked conversation on exploring intimacy, reproduction, and fertility in early age onset cancer patients. In this session, we will explore proactive fertility counseling, including risk awareness, preservation strategies, and how treatment decisions shape reproductive outcomes and long-term sexual health. We'll look at body image and hormonal changes post-treatment and their impact on sexual identity, function, and intimacy. The psychological, sociological, and physiological dimensions of sexual dysfunction, survivorship, and models of supportive care. We'll look at navigating challenges and system-level barriers that limit access to fertility and sexual health support, including gaps linked to treatment pathways and care coordination. In a lot of ways, this is a new focus because the early age onset cancer demographic will be so heavily impacted by things like fertility, intimacy, and even more than we've seen for so long in the average age demographic. It's not to say that one care or concern is more important, but more to say that we have to make sure that we're looking at things from a strategic perspective. Relevant to our discussion, I myself am a 3-time early age onset cancer survivor, thyroid cancer twice at 29 and 31, and then most recently at 37, I was diagnosed with a late stage colon cancer, where my life was greatly extended in large part to the utilization and identification of my MSI high status, so a tumor biomarker that encouraged immunotherapy treatment. I will attempt to bring my personal perspective into the conversation. As a patient, reproduction and fertility concerns and efforts have been tightly tied to almost our whole journey. And I say our consciously because it's not just myself that went on the journey, especially when we're talking about fertility, but also my partner. From things like sperm function testing, sperm banking, We went through IUI, IVF appointments for almost a decade. We went through multiple miscarriages, failed embryos, hidden costs within the idea of funded fertility cycles, and then seeing our life savings being spent on what at times feels like a hazy dream while you're still trying to socialize at work, trying to go to school, trying to pay tuition, all that day-to-day life. In my case, we had collection calls even during our cancer recurrence for the sperm banking fees that, for me as a patient, I didn't fully comprehend wasn't part of our coverage because it's being explained in the middle of a recurrence. That can be very difficult to comprehend and intake. Now, that being said, perspective is also a big element in the world of an early age onset cancer patient. So I also want to close my intro with the reality that through all that struggle and pain, it's also the evolution of fertility treatments and care. We now have 2 healthy baby boys. And when you start to talk about it, you'll find that so many other people have been down this very similar journey. And that's where the stigma really comes into play. So a special shout out to Dr. Boratz, who looked after us. And he made me promise that if we did have a family, that they would become Toronto Maple Leafs. And Dr. Boratz, we're still on that path, although they're very young. I would love now, if I could, to please pass our session focus over to our patient expert for our session today, Julie, a stage 4 inflammatory breast cancer patient and a patient advocate who's blazing an advocacy trail on behalf of all of us early age onset patients. So Julie, I'd love to pass it to you and hear a little bit about your experience.
Yeah, sure. Hi, everyone. My name is Julia. I go by she, her. So I have stage 4 inflammatory breast cancer. And it's like a whirlwind. Like what Christopher was saying, when I got diagnosed, fertility was the last question, if not even a thought, that my oncologist had. So I was diagnosed at stage 4 at the age of 33. So you can imagine, I wasn't really thinking that much about my fertility options. I was single at the time. And I remember distinctly, right when I was just on my way to go get a PICC line inserted, I asked my oncologist, well, wait, what about fertility options? And so unfortunately, I ended up having to start my chemotherapy within the following week because inflammatory breast cancer is extremely aggressive. It was in a couple of major organs. And so, my form was sent to the fertility clinic, got lost in the pile. And by the time I actually got to speak to a fertility doctor, I had already had my first shot of Zoladex. So I was put into medical induced menopause. That is coming on 3 years now since I was diagnosed. I've already done a couple of tests to try to see if I can eventually see what my egg count is, harvest my eggs. But I'm currently back in menopause again and on my second line of treatment. So I started a new chemotherapy in June. So it just kind of seems like harvesting my eggs at this point is not in the cards at all. I'm currently in menopause. This time around, it's way different than the first time. I found the first time when I was in menopause, for example, TMI, if any of my family's on the call, my libido didn't change at all. Just like a lot of going through the emotions and crying because I dropped something on the floor, versus this time, it almost feels like I have zero libido. Talking about family planning is extremely difficult for me. Been trying to look into what adoption looks like for somebody with stage 4, if that's something that I'm interested in pursuing, or now I'm starting to do some research on donor eggs, having conversations with my partner. Are these some options we're interested in exploring, and like just kind of having some difficult conversations there. I have to do more research on what I can do to make my life a little bit easier now being in menopause. You don't know if you have a yeast infection, a UTI, if your vagina's dry, like all these kinds of awkward things that I'm trying to navigate and chat with my friends who are not in the same spot at all. A lot of them are having babies and talking about getting pregnant and that kind of stuff. So it's kind of interesting. I'm like, well, I don't know what's happening now when I have sex. I'm dry as sandpaper, and this isn't fun for me anymore. So it's just kind of like been a lot. I'm thinking about some of the money that I've spent trying to see what my egg count is and stuff like that. And I'm honestly dreading my appointment with my fertility doctor to talk about it, because it's like, yeah, I don't think harvesting my eggs is an option. When you're not constantly, but I'm on like a every 3 week cycle. So I have to go for treatment every 3 weeks. So previously I was doing Herceptin and Perjeta. So you can't, or not that you can't, but it's advised to not get pregnant or conceive during that time. So a lot of my conversations with the fertility doctor have been around like checking in with my oncologist on when is a good time to pause treatment. And so I'm always nervous to bring this up to my oncologist, and her and I have a really good relationship, can usually ask her anything. But asking her when can I take a pause in my treatment is like the scariest thing in the world. And now knowing that like my cancer has spread to, my spine and my lungs, and it's kind of all over at this point, I don't think wouldn't even feel comfortable actually stopping my treatment for 6 months just because of the risk. And so it kind of weighs on you, because when you're in a fresh relationship and you're trying to like have these conversations, and like I want to have them now, because like I need to know, like if I want to do adoption, like it's going to take time, or get a surrogate, these things take time and they cost money. And I don't have a billionaire, trillionaire salary to just like, all this stuff will require a lot of planning, and it weighs on you, and it sometimes feels isolating because, again, a lot of my friends are not in this space. So I'm really grateful to have my breast cancer and cancer community friend of folks that I can like ask them about, top or vaginal estrogen, or like, I'm afraid that my vagina is going to dry up and close. Like I'm not, you know what I mean? And I'm so young. So it definitely weighs on you around everything and how you see yourself, and see your hormones are changing and you don't even know what's happening. And it's like, who do you ask? Who do you talk to? Like, you already have a ton of doctor's appointments. Trying to see a natural path on top of it is so overwhelming when I'm having to navigate 1 to like 3, appointments a week just for my own like breast cancer stuff. So it's a lot. But I turn to organizations that have resources, or, follow folks like who are professionals in this area to see like, what are some things that I can do? Who can I talk to? And yeah, it's a little disappointing that when I go to my oncologist and I'm like, my period stopped, I'm upset that I don't have a period anymore. And it's like, okay, I'll put that in the note tracker. And then like, that's it, right? Because I know their biggest concern is ensuring that I stay alive. But I know sexual experiences and health and identity are just part of being human. So it's a little frustrating sometimes when it's like, I don't, like, I'm supposed to turn to you. You're my, my oncologist, my care team. This is all happening because of cancer medications. It's not a natural progression. So it does get a little frustrating. But I just need to like pull up my big girl underwear and say, I have questions, and like, who do I turn to? Like, where do I go? Sometimes if I talk to my gynecologist, she doesn't really know anything about the cancer world, and sometimes just puts her hands up. So yeah, but that's it. I could keep going on and on and on, but I'll pass it back to Christopher. And yeah, wait for the Q&A.
Thank you so much, Julia. Thank you for bringing those very real conversations and discussions, because this is what an early age onset cancer patient discusses with their families, with their close loved ones. So we do very much appreciate it. We're now going to turn to our panel discussion. The intention is I do have select individuals I'll turn to if we have time. Please feel free to raise your hand if you have a contribution. Ultimately, we want the experience to be as great for the viewer as possible. So if you have something you want to add in that you feel is important, please don't hesitate to do so, okay? So to start, and we will lead off of this first discussion idea, reproduction is such an important natural element in the psychology and biology of an early age onset population. But so many patients feel underprepared and ill-informed on both the options that are potentially available to them and their spouse, and the side effects of the medications required, but then also the cost barriers and those the lack of consistent support needed to afford them. From the differences, again, we talked a little bit about IUI, IVF, information on the possibility of egg donation and sperm banking. So the question we pose to you, and Liz, I will turn to you first with this question. How do you feel we can improve our systems to address these gaps and help build fertility preservation strategies that work alongside treatment decisions to help improve reproductive outcomes? Oh, you just unmute, Liz.
Sorry. It's a loaded question. I think it's, you know, I went through the cancer system almost 20 years ago. So I'm obviously speaking a little bit retrospectively on this, but, you know, we went from doctors almost being like, why are you even talking about this, to it actually coming to the table and being a bit of a conversation now. Although Julia, I unfortunately, it seems like it was sort of half there for you. And thank you again for just sharing your whole story. It was just incredibly, thank you for being vulnerable like that, because I know it's not easy to dig into that. It brought back a lot of memories for me too, listening to it. And you know, how do we do that? That's a really great question, because we're in a healthcare system that definitely knows how to treat a chronic condition or an emergency condition and facilitate that type of care. But when we look at the adjuvant or related things around a disease, our healthcare system is not necessarily, I mean, we all see it now, there's a lot of deficiencies in it, and unfortunately it's not always built to address the side effects of a treatment or the things that might come about because of an initial diagnosis. So I think, you know, how do we address it? It's, you know, for me, it was always a big, when I was sort of driving at the helm of Fertile Future, which used to be a far more necessary organization because we didn't have government funding for fertility treatment and it provided some financial assistance. You know, when that was sort of being driven, we didn't have those conversations happening at all. And we really tried to lean into the nursing staff that surrounds an oncology patient, because we do know that they spend so much time with these patients. So I always felt like that was a really important, you know, touch point for getting information to a patient in a way that's timely, is awareness based, is very much so looking at a patient and seeing this day to day. And like a nurse, I feel, is more likely to be able to bring this up. I think the silos of fertility and oncology have to continue talking to each other, because these are two separate fields of medicine. But they very much so are pivotally important to know what the respective fields are doing in order to treat younger cancer patients, especially. So, you know, having those two fields talking to each other, knowing what's available in terms of services. When I started my journey, my oncologist did not know you could actually freeze your eggs in Canada, as an example. So that was in 2006, 2007. We've come leaps and bounds from egg freezing being an experimental procedure to now being a more standard option of care in fertility. So I think we've really come quite a bit of distance, but again, it's going to take time. It's going to take resources. It's going to take people in the separate areas engaging with the cause and the importance of the issue. And I know that Dr. Dunn is here today, and that's she's been an important voice in this as well. So I think looking forward, you know, we need to think of who are the people that can really carry something like this within the medical systems that aren't overloaded. Is it the psychologist? Is it the psychosocial care workers? Things like that. Is it identifying an individual at every cancer treatment center? Or is it flagging, putting that check mark on a form where fertility preservation has been addressed with this patient? Yes, check. You know, those little touch points are so pivotally important. And the bottom line is, and I found this when we had our Power of Hope program with Fertile Future, is identifying an ambassador or a team member within every cancer center who's able to advocate for this cause, who's able to identify this to the other staff members, provide education and awareness. And I think that's going to be paramount. But I think at the end of the day, and I can say this as someone who's 20 years out from their cancer treatment now, it's going to take time, and it's still not front of mind, and rightfully so to a degree in comparison to survival, right? So in a system that does not have enough resources, it's always going to go to the most chronic problems or issues, which is survival for a young cancer patient. So It's going to take time. It's going to take resources, and it's going to take patients like Julia and myself and you, Christopher, talking about the importance of fertility in your future and other health concerns. But fertility is a big part of everyone's lives. It's how people sort of feel like they leave that mark on the earth when they leave, how they fully experience life. And that is something that a cancer patient has just as much right to as the person sitting next to them that doesn't have cancer. And it's remembering that and making that a priority, and remembering that patients are humans that want the exact same thing as people that aren't patients. So that's sort of my spiel on this. Is it's a loaded answer because it's a loaded question.
Yeah, and a great answer, Liz. Thank you very much. And you know what? You set me up perfectly. I would love to go to Dr. Dunn and get your perspective.
Yeah, I mean, I think I would echo what was already shared already about how when you're a young person with cancer and you get that diagnosis, the amount of information that you have to absorb and that has to be conveyed to you from that appointment with your doctor is just absolutely overwhelming. And the number of pieces that have to be coordinated. So oftentimes fertility does become sort of a secondary thing. It can get forgotten. And just from a logistics standpoint, I know that there are people on this call that say, you know, what does fertility preservation actually even look like? So let's say everything goes perfectly, right? So let's say you have a conversation with your oncologist, you're diagnosed with something that's going to impair your fertility. Most commonly, that would be breast cancer because the chemotherapy is toxic to the ovaries. And as a gynecologist, I'm speaking for women, but you know, anything that might require radiation to the lower half of the body, we could talk about colorectal cancer, endometrial cancer, things of that nature, or else general chemotherapy. We do see leukemia, lymphoma patients, so cervical cancer patients. So those are some of the most common, by not at any means an exhaustive list. But let's say things go perfectly. You're a young person. Generally, we see patients, you know, under 35 or under 40 who wants to have a family or wants to expand their family in the future. What does it look like to do fertility preservation? Well, for people with testes, I mean sperm freezing. Now, often if you are sick, sperm numbers can be low because the body recognizes that maybe sperm production is not the top priority for your health right now. So in some cases, you can get enough sperm with one banking, and that's certainly better than nothing. In other cases, people with testes may need to bank, you know, a few samples of sperm. That sperm remains frozen, and it can be used essentially indefinitely. It doesn't get freeze or burn. Depending on the count, it can be used for insemination in the future, or it can be used for IVF. As a person with ovaries, it's a little bit more complicated, of course, because, you know, the eggs are on the inside of the body. So that means, for the most part at this stage, it means going through an IVF cycle where you have to take injections. Those injections are usually 8 to 12 days worth, followed by an egg retrieval procedure. So the fastest we can get that done, even if it starts right away, is usually 2 weeks. And I want to say it's probably more realistically 2 or 3 weeks, because you do have to come, even if we see you the next day, and at PCRM we really try, the oncologist picks up the phone, we will try to see you the next day. But let's say we see you right away, you've got some ultrasound, blood work, we try to work around the cancer appointments and try to get that egg freezing done. But it still takes 2 or 3 weeks. And I think, as we heard, you know, Julia was so well articulated that can be at odds with what's best for your cancer treatment. What's looking forward in the future, we're looking at things like ovarian tissue freezing. And that's currently done for young people with cancer who haven't started their periods yet. But I think moving forward into the future, freezing an actual piece of the ovary and then actually reimplanting it in the future may be more of a mainstream technology. And they're also looking at stem cells and sort of, quote unquote, if you will, say, you know, ovarian rejuvenation. That's sort of a catch-all term that is sometimes misused. But there are a lot of research projects in this area. The key thing, as we've heard over and over, is knowing about them. Is just putting up your hand or having somebody advocate for you, as Liz so well articulated, to say, let's have a conversation about this before those therapies start that could damage the ovaries or the testes, in some cases irreparably.
Thank you so much, Dr. Dunn. Very, very much appreciated. And I guess I'll just add as well, because you talked about, getting to patients early on in their journey to be able to educate early on and know those risk factors. I do believe that personally, this is a personal belief, that the early age onset clinics would go a long way in getting that type of focused improvement by building things like patient experience and data that we talked about earlier. We heard in our earlier session, 83% of early age onset cancer patients from our pan-tumor patient survey reported no access to a dedicated early age onset clinic or a adult or young adult clinic. And those models of care, I think we had 66% said they were completely unaware that they even existed. So from my perspective as a patient, when we have that type of ability to have those centralization of resources and understanding of that wraparound care service, I think it's really, really impactful. So I see that as a potential future benefit if it's something we can advocate towards and get to. I will now move on to the second question. And this is, stigma can be such a difficult barrier. And some of the areas that we see a lot of stigma include topics like body image and hormonal changes post-treatment and their impact on sexual identity, sexual function, and intimacy. I ask you, and I'm going to turn this over to Julia first, what are your thoughts and your experiences? I know you shared a little bit, but maybe you want to go into a little bit more depth.
I guess, yeah. Like I mentioned, like going into menopause for the second time. So yeah, I've just been noticing like it's impacted my overall aura. Well, I think like I also had spine surgery. I did radiation in the summer. So there's like a lot of things that have just happened. I just added a new cocktail drug to my cocktail mix a couple of weeks ago. So like my whole energy levels have completely declined. I'm feeling way less social. I have zero libido. And then now I'm currently just trying to do more research around can I have estrogen and like what does that look like? I've been gaining quite a bit of weight. Some of it I'm not sure if it's from now I have to take pre-meds when I go for my treatment, or if it's also just like I'm a little depressed, so I'm eating my feelings, so I'm gaining weight. So there's like a lot of things, and some of it is medication, and then some of it is just like the cause of the medication, and like the fact that I had spine surgery because there's cancer in my spine and I haven't been moving. I can't walk for very long. I can barely carry my groceries home. So it's just like I'm kind of in like this rut, but again, I kind of just like lean on the cancer community and see what resources are available and like what are some techniques that other people are doing, and just trying to like just kind of get more information because I know I'm not alone. Like the first time I didn't have this experience, but I have friends in the cancer space that have gone through similar things. So now I'm like thinking back to what they said and like reaching out to folks just to understand, like, what did you do in this situation? But I'm someone who's like really comfortable about asking folks in my network for help and support. But I recognize for some, they feel like they're carrying all of this on their own. So I've been trying to be a bit more communicative with my partner of like, this is how I'm feeling. And these are the reasons why things are changing. But it's hard. It's not easy. And it does feel isolating. So I find it just kind of, when I'm ready, I'll reach out to folks or search a Facebook group to see like, what are other people's experiences. And just wear a lot of extra large clothes because I don't feel hot and I don't want to buy new clothes, but everything's too small. So I just gotta make it work. But yeah, that's pretty much it.
Yeah, it's great. And the peer-to-peer support can be so impactful to a patient's journey. Just getting that, being able to lean on somebody who's walked that a little bit. I'd love to turn to Dr. Walker now and just hear your perspective.
Thank you. There's so many different components to this. I think we could have a webinar on just body image and on just sexual function and just fertility. So I'll speak to an overview of a few things. I think, it's such a challenge to talk about these topics because they are so inherently vulnerable. And so kind of putting yourself forward and expressing that I have this concern in an environment where we've heard a lot of discussion already today about how the priority, or the priority and perceived priority, is that healthcare providers and physicians are trying to help you prolong your life, right? And so, there might be a sense of kind of dismissing our own concerns, saying, well, I guess it's just my body, or I guess it's just my sexual function. I'm supposed to just focus on, surviving this and getting through my treatment. And, I think that I got a lot of that resistance. I've been working in this area, educating providers for 2 decades. And I used to get a lot of that resistance in the beginning, and I have seen some improvements, which is great. But as we've talked about, it is slow to see practice change. And so the more we see other providers agreeing that this is important, research studies demonstrating that this is important, patients saying, hey, this is important, we do see more emphasis and more resources. That being said, there's a lot of room for improvement. And I think when it comes to sex specifically, as a society, it's so interesting because on the one hand, we're always conditioned that sex is taboo, we shouldn't talk about it, that's private. Even within the context of a couple's relationship, it's often just like assumed my partner should just know what I want. I don't even necessarily know what I want. And so to actually gain the language to be able to talk about sexual function, changes in the body, what we want for our sexual relationships, I think it's challenging because we've never practiced it and we've never said these words out loud. And our communication, like anything else, is a skill. And so the more we say it, even if it's just talking to friends, talking in peer support groups, talking, to other people about what you're seeing around you in the news and the media, I think that actually helps build up our confidence to say some of these words out loud. And, I think we're continuing to get better. We need to practice that. And I want to acknowledge again, I think we're at this really like this turning point where we're seeing a lot more attention come to some of these topics. And when I first started out my master's thesis work, it was in prostate cancer. And I can remember I think it was Bob Dole. It was the US politician who was talking about erectile function problems after prostate surgery and medications. And this was finally, like, I think it was on Larry King, like someone was saying this stuff out loud. Now, 25 years later, women are getting their moment. And I think menopause is having its moment. We're seeing a ton more attention. And women in particular are demanding better reproductive health care. They're demanding pain management when it comes to reproductive procedures, and more attention, research, resources to like pelvic health concerns such as endometriosis, right? So if you're on social media, you're seeing this stuff generating a lot more attention. And I think as a natural extension, we will see this come into other areas such as sex and cancer. We know that there are great guidelines in place, the Cancer Care Ontario, ASCO, these guidelines have put forward that the onus needs to be on the provider to bring up these discussions with patients. It still isn't necessarily happening all the time. And as much as I don't want to have to put the responsibility on the patient, I also do think that when patients are speaking up, when patients know that it is a legitimate and valid concern to bring these questions to your doctors and to your healthcare team, I mean, it is very valid and very legitimate. So I want you to feel empowered to bring your questions to your healthcare team. And that I often say to my patients, like, the squeaky wheel gets the grease. So if you are willing to say something, there will be movement within the system. So we are at I think, an opportune moment here. I think we'll continue to see improvement. And I don't want to continue on with this idea that sex is taboo. It is a fundamental part of people's quality of life, and it helps contribute it to satisfaction and longevity in relationships. And we know that relationships are an important indicator of survival through cancer treatment and through diagnosis and cancer detection. So it's not just sex is about pleasure. This is frivolous. This is actually a really important indicator of quality of life and effectiveness of your treatment. So I'll leave it at that. We've got more to discuss, but thanks for giving me the opportunity to speak to that.
Of course, Dr. Walker, thank you so much. And I'd love to turn it over to Dr. Cohen now and get your perspective.
Thanks very much, and thank you everyone for sharing your personal stories. It's interesting for me listening and learning always, no matter how long I've done this, I learn every day. And if I can take from somebody, a good friend who's recently had a hysterectomy and does not have cancer, but had hysterectomy for benign reasons, and she told me her life just fell apart. And she would go back to her gynecologist and say, what's going on? And they're saying, oh, well, it's just normal adjustment to post-surgery. And it went on for a year for her, unfortunately. And now she's talking about it to more and more people. So imagine you put a cancer diagnosis on top of that, the impacts of what we do is immense. And I want to go back to where I started. I started as a general obstetrician gynecologist, and for 25 years, I've been talking about hormones, and sexual medicine was a subspecialty of mine. I spoke at cancer agencies and I said, you must ask at the first visit about sexuality and fertility. You must. It's a crime not to ask. Then I became an oncologist, and I was like, how can I even ask them that at the first visit? I'm telling them about cancer. I don't have time. I need this. And time really is an issue. But the key for practitioners is you don't have to ask them. You have to give them permission for it to be an issue. And in fact, don't ask them about it. I just say, hey, listen, where we're going, this can affect these issues. And this is a place you can discuss them if they ever come up. And if I can't help you, I'm going to find somebody. So for me, the number one point, and if I can go back 2 steps here, everything I do affects that. I don't give chemo. I predominantly am a surgeon. I cut out uteri, I cut out cervixes, I cut out ovaries, I cut out vulva, I cut out clitorises, I cut out vaginas. Everything I do affects people in a massive way. And so, of course, their image is going to be affected. Of course, all those things are going to be affected. And to not give them permission to discuss that or to bring it up is just, you just need to find the time, that first visit, to say, it takes 10 seconds. Hey, this will be possibly an issue for you. You can discuss that if it is. The next thing for me as a practitioner that I think I can add to what everybody's already said is I have a team. So my team includes Dr. Dunn's clinic. I phone their clinic, and I tell you, I have phoned them on a Sunday afternoon and they've gotten things done in 2 weeks. So you have to have your team of people that you can approach. You simply cannot do it all on your own. I have a traditional Chinese medicine practitioner who practices mind, body, soul healing. I send people to her. I have a sexual medicine specialist down the road. I send people to her. We have a nurse practitioner at the Victoria Cancer Agency who does sexual medicine issues, pain, vulvodynia, those kind of issues. I send them to her. We have a general gynecologist in town who specializes predominantly in hormones. I send people to her. I can do lots of it, but I can't do it all. And so you know, the best way is to find the people in your community that are interested in this. And I see Lauren Walker would be somebody I would be latching onto. If you were on the island, I would be sending people to you. So for me, there's no question what we do affects all of these issues, physiologically, emotionally, psychologically. So have a team that you can use. You as a practitioner where I'm at, I love to talk about this stuff and to help people with it, but I don't have the resources and time to do it myself. So build a team and use them. The other thing is, for me, as I continue to practice, I still learn this. Listen and hear. When people say something, they don't always say it exactly as you expect. They might have said it couched in some other language, but try and listen and hear. And that takes being in the moment. You have to be present to hear what people are saying. And then you can ask, are you asking me this? Are you saying this? So if I can bring anything, here's one other thing I was jotting down as I was listening to people, and this is a tricky one. This is a part where I struggle. I would love to say, hey, I know Kathy over there who's had the same issue as you. Here's a number. Why don't you guys go and talk? Ethically, we can't do that. And that's for me a real barrier. If there was a way that we could work on the ethics around that so that it isn't a barrier to people finding support and people who'd be willing to give that support. That's my one area that I would ask people to think about and work on. But the rest, if the message I can get you is you don't have to discuss it, you have to open up the topic that it's fair to discuss in a future visit when they're past all of this acute stuff, and have a team around you.
Thank you so much, Dr. Cohen. That was absolutely incredible. And I will share, organizations like we have My Cancer Companion, which could provide that type of access and peer-to-peer relationship that can take place. So these resources are out there. It's just a matter of making patients and caregivers aware that we're here. I'm now going to move on to, and I am conscious of time. The conversation is wonderful, and anytime you have such an incredible panel group, we're gonna talk. So I'm going to now move a little bit quickly into our fourth question, and I'm going to try to get the perspective, if we can, be as concise as we can when we're speaking to it. But I want to get the perspective of everybody if we can. Equity of access created by gaps in information sharing, system clarity, costs, geography, and even referral consistency are barriers we see. What are some of the ways you see system improvements being implemented that would help close the information and access gaps for the early age onset cancer patients? And Liz, I'm going to turn to you quickly first.
Oh gosh, I was hoping you wouldn't come to me first, but here we are. So, I mean, I think just really ideally, it's, I almost think like a checklist, like some sort of what are if you're a patient that's in your 20s, in your 30s, getting diagnosed, I mean, especially your 20s, my God, like I was 24, I'm going to be 44, this is my next birthday. And you are just getting your wings are getting clipped before you even start flying. And there's so many things that can be addressed in the moment of diagnosis or the appointments right after that are going to really affect your life. And I think it's looking at what the prospective diagnosis is and what are the potential issues that could come up so that the patients can watch for them. Right. So knowing, no one talked to me, people said your radiation, your pelvic radiation is going to cause menopause, but no one addressed the menopause until I was like, I'm really hot and I feel really uncomfortable and things don't feel right. And they're like, oh, well, maybe you're already in menopause. We didn't think it would happen that quickly, but I sure enough, they ran the bloods and the things that you should look for and be expecting and really prepare patients for potential things. 7 years after I had my treatment, I got diagnosed with vulvodynia, but first I suffered for 7 years in pain. So what are the issues that could come up that you could watch for that we could somehow address instead of you suffering for years, right? The fact that, sexual health and identity, I basically thought I was not going to be a sexual person until I was well into my 30s because I simply avoided sex for years and years and years because it felt awful. But once I started to actually address the things that could help that, it changed my life. But it was getting to that, even admitting it's a problem because you're so traumatized from the fact that you have cancer and you've gone through the slash, burn, poison, rigmarole. It's damaging to your life. And then not to mention the career and the finance, there's so many things that are getting damaged. And I think about it now as 20 years later, I am a mom of someone who I never want to have to go through what I went through. And what are the things that I wish were addressed for me, for future patients, and where are the lists and the touch points and the prospective things that could come up for you, but to prepare these people, because we know what these things are within the medical system already that are going to come up for the different cancer sites. Why aren't these written down somewhere where people can actually address what could come up? What are the things? Because the knowledge is there and it's getting into the right places and the right at the right time for people so that they can actually have a positive outcome on their lives. And that's all I'm going to say about that. I don't really know how to roll that out, but I know that it should be done, and I know the information's out there. So how do we take that information and make it a resource or a tool to actually help improve quality of life during and after cancer?
Thank you, Liz. And first step is start talking about it, exactly what you brought forward. I'd love to turn over to Dr. Walker.
Yeah, absolutely. So we've identified lots of gaps, and I think in some of our centers, especially the major tertiary centers that are in larger cities, we are seeing better resources related to sexual health. I think we've done a lot better in terms of sexual medicine, more of the biological treatments, medications, but I think we need to obviously keep improving on the psychosocial aspect, recognizing that cancer doesn't just impact the individual, it impacts the couple. And so more couples counseling, couples-based resources, as well as, again, like body image. I think that that's something that there are a couple of resources across the country that I can think of, but these aren't widely available. They're not, it'd be great if they were online, if people could access these resources and sources of education from their homes rather than having to travel into major centers. One thing that I started to do just before we logged on for our talk today was pull together a bunch of different resources. If you take a look at my Instagram account, everything's on my story. So I think I've reposted about 15 different accounts that could be followed, or resources or links that can be downloaded. Perhaps it can be put in the chat box, but my Instagram is Dr. Lauren Walker. And I think that, I get these questions all the time. Where do I send patients? I've got this question, this resource, who do I send them to? And it's folks like myself who have all these connections, who know, oh, this person's doing this study's recruiting, these are current resources, this webinar is coming up. So, take a look at those different accounts that I've shared, because that's where, if you follow those people, they'll be advertising new webinars and new things that can be helpful. So again, access whatever details you can find through these types of connections with people. And I think even we did a webinar earlier this year on colorectal cancer and all the different strategies around vaginal health, sexual health, erectile aids. So dive into some of those resources that are already recorded and posted online.
Thank you so much, Dr. Walker. Dr. Dunn, I'd love to turn it over to you for your perspective.
Okay, I'll start with a few good things, and then I'll share some development areas. So I think the things that are working for patients are virtual medicine has really changed how we're able to see patients. So speaking as a fertility doctor in BC, before COVID, we could not see patients by phone or by virtual medicine unless they paid out of pocket for that. There was no fee code for it. There was really no referral process for it. They had to be in our office. COVID changed that, and hopefully when they re-up on the agreement coming up, they will keep those virtual appointments available, because it means I can literally see tomorrow somebody who is on Vancouver Island or north in the province or in the Yukon. So virtual medicine is huge, as well as progression in how we can assess ovarian reserve. So unfortunately in BC, you have to pay for the anti-Mullerian hormone test, which is a blood test that looks at essentially how many eggs you have remaining. It's a really valuable test to look at the fertility potential for freezing eggs, for example. That is private pay, even if you are a very young person or a teenager, young girl going through cancer treatment. In other provinces, it's not private pay. So although those tests are great and available, I would love to see, number one, shorter waiting times for looking at something like a sperm test or for getting into life labs. And I would like to be able to see uniformity across the provinces in terms of not having to pay out of pocket for those tests, particularly when they're related to cancer treatment. The other thing, and sort of building on that, is one of the great things we've seen this year in BC is that there has been some funding for IVF. That means, and it's very validating to patients to say, you know what, fertility is important and we're going to pay for that. It's a disease, it's recognized by the International Classification of Diseases, and therefore it's worthy of treatment. The flip side of that is there's not enough funding. Now, that's true in all aspects of healthcare. There's not enough funding. In Ontario, there is funding for an IVF cycle. We know in Manitoba and some of the Atlantic provinces that there are other means of funding parts of the cycle. I served as vice president of Fertile Future, which is an organization, national charity, trying to provide some subsidy for these treatments. But ultimately, it's very patchwork across the country. And I would love to see more uniform access and more uniform coverage for patients across the country to fertility services, specifically egg freezing, sperm freezing. And finally, I'm just going to put a plug in there, decriminalization in terms of the federal law that governs surrogacy, egg and sperm donation, because currently it has to be done altruistically, which really limits the availability of these donors. And so if you do, because it's criminal offense to go against these laws, obviously the availability of surrogates and egg donors and sperm donors in Canada is very limited. So I think from a federal level, there's a lot of room to look at how we can give patients better access and how we can better subsidize these treatments across the country.
Thank you so much, Dr. Dunn. I could not agree more. Those costs can be so damaging to those who want to have, a potential family in their future. So we have to raise the importance of those costs.
On that, I personally had my daughter through surrogacy and egg donation and worked in the industry as well. And it was well over $100,000 by the time I added up all the expenses that I incurred. So and that's very prohibitive for a cancer patient who hasn't been able to do the same things in her 20s to establish her career as the rest of the population. So it's another ding to make things more difficult.
Yeah, you're absolutely right, Liz. I'd love to turn it over to Dr. Cohen, please.
Yeah, I stick to the two things. One is it's been amazing to listen to you, Christopher, and Julia and Liz telling us about your stories. And I think that's what we should use. So I think we should push our cancer agencies to establish a support network for patients so that you can go to a group and access them easily and say, hey, what was your journey through this? Those exist out there. Most of us in the cancer agency don't know what they are or who they are to refer patients to. So if you had the cancer agency establishing those kinds of things, asking people like you three, hey, could you help in some way with this? And the second part of that, I think that makes a difference is the axis is the patient and the caregiver. Well, if neither of them are aware, we've got a problem. So awareness for the patient is if we could get the cancer agency to set up these support groups, but then to bring people like you three in at lunch hour, instead of going through Journal Article 372, let's have a real person come and talk to the caregivers, the physicians and the nurses about your journey. That's what it takes, is constant reminder. This is an issue. This is an issue. I know you're busy. I know you've got a million things to do, but this is a real person. This is the journey. So for me, those two prongs would allow the patient and the caregiver to move.
Wonderful, Dr. Cohen. Thank you so much. Julia, I'd love to get your perspective. I know to everybody watching, we have about 7 minutes left. If you have any questions and we don't have time to get to them, please send them in anyway. Our goal would be to answer them for you. Even if it's not immediate, we will get back to you to make sure that we provide the best information we can. So Julie, I'd love to hear your perspective.
Yeah, I'll be super quick because there's a few points around access across the country and finances that have already been chatted about. But I think one of the biggest things I realized is that awareness and early detection really matters. I never knew that a cancer diagnosis, regardless of any kind of whatever your cancer is that it impacts your sexual health or fertility. I had no idea. And it made me spend 3 years regretting my entire life thinking, oh my God, I probably should have had a baby in my 20s because I can't have it now. Or you go through all this, these thoughts around grieving the life that you're missing out on. I never wanted a family until I was in my 30s. And now that opportunity is changing. But I think really it's awareness, to know that a cancer diagnosis comes with, like, your fertility can be impacted, your sexual health can be impacted. This is why, like, early detection for inflammatory breast cancer needs more attention, or why just like self-checking and all these kinds of things like matter, like knowing your body. If something is coming, if something new is popping up, like go to a walk-in clinic, go to your doctor, bring that up, because I don't think a lot of people really realize what comes along with a cancer diagnosis and how that impacts your life even after you're, some folks, you may be done with your cancer, and it may never occur, but some of these side effects will also never leave you, regardless if your cancer has been resolved or not. So I think that's just like my biggest thing really, is that awareness piece, and just more advocacy for folks to just be your own self advocate, do your own checks, pay attention if something's changing. And then I just think it needs to be more of like a common fact that like your fertility and sexual health can be impacted by a cancer diagnosis. So that's
Thank you so much, Julia. And I guess if I could add just a few pieces, I think cost implications involved in fertility treatments really have to be a bigger piece of that look of what's the cost to a cancer patient. Because we know those who've lived through those fertility journeys, that cost that we see in that $30,000 range would easily be lower if we included the fertility cost and those elements. So I'd love to see that be brought more into the conversation, because we don't always have patients share this. So we don't always capture that data of those who couldn't have kids, or those who weren't able to because of those cost barriers. And then the last piece is speaking to it. So creating the forums to have conversations exactly like the ones we just had. It goes such a long way for a patient. I can speak from my experience, seeing all of you have this conversation, and the passion in your voices goes a long way in my confidence that we can advocate to change. So I appreciate the work that everyone's done. I thank you so much for being here. Of course, I want to make sure I send a huge thank you to Julia for sharing her vulnerability, her strength, her courage, and ultimately your story, Julia. It's so impactful, it's so powerful. And thank you all so much for contributing to this heavily stigmatized topic, and for trying to help magnify the awareness necessary to close those gaps that we know patients and their loved ones experience when it comes to intimacy, reproduction, and fertility in cancer care. We've got a little bit of time, so I think we can try to answer at least one question. So to our panel, please feel free to raise your hand. I'll read the question off. And if you'd like to jump in, please feel free. We have about 3 minutes. And the question that I have, can we talk about navigating a relationship during cancer care? This happens a lot and more often than we like to talk about. So, maybe we could talk about the idea of a breakup, those elements within a relationship. Would anybody like to talk to that item?
As your resident couples therapist, I'm happy to chime in a little bit. I'll be brief. We know that the dating scene is challenging as it is, let alone bringing in a diagnosis. Letting folks know you don't know about what your future holds, you don't know what your fertility might allow or what your function allows. And I often say, introduce that information in a staged approach, get to know someone over a coffee date. And then, like, as you know, is this person a trustworthy person? Do I even want to talk to them again? So adding in little bits as you're getting to know this person, rather than feeling like you have to give them your whole spiel right away. That's one tip for dating. And for couples, I just think it's so important we recognize that this impacts the couple, not just the individual. And it might mean that, maybe you could have used some couples therapy before, but like, this is a really great excuse, a good reason. We've got something big that we need to tackle together, and we have to have better communication around it. Get your foot in the door to a couples therapist, and then you can talk about all the other things too. So lots of folks do have insurance coverage for psychologists or for registered social workers for some sessions, and many cancer centers do have some degree of psychosocial support. It may not include couples expertise, but again, I wouldn't hesitate to inquire about some of those resources in your area, maybe on Psychology Today or some of these resources, rather than just through your center.
Thank you so much, Dr. Walker. And we are now out of time. I want to thank again everyone so much for your engagement, and I am now happy to pass it back to Cassandra.
Thank you, Christopher. What a great discussion. I will share just in respect of the resources that were mentioned. We do have Dr. Walker's Instagram tagged on our account currently. We also had some audience comments about some wonderful resources developed by BC Cancer and Royal Roads University, as well as Alberta Health Services. So thank you so much to our multidisciplinary clinicians who provided really valuable insights. It would be fantastic if all patients had the opportunity to have clinicians like the three of you working together for, holistic, age-appropriate care for each and every patient in Canada. And to our three patients who shared their personal lived experiences through this discussion, thank you so much for your vulnerability and your candidacy. And, you sharing your lived experiences makes such a difference for somebody who's feeling lonely or isolated. And it really helps truly to break down some of that stigma. So a heartfelt thank you for that. And we will be right back with our next session on managing the cost of cancer.